Hello, good morning. I hope everyone can hear me. If everyone could just give me a thumbs up if they can hear me. Super, lovely. So welcome and hello to our first ever virtual SCTS annual conference. It has taken a lot of hard work and commitment from the annual meeting committee, but we are here, so welcome everyone. And I really hope you enjoyed today, which is the University Day, but also if you're joining us on Monday and Tuesday. So I hope you enjoy the main meeting and the CT forum as well. However, more importantly, and I am allowed to say that as I've been involved in the planning of today, welcome to the first ever SCTS Nursing and AHP Research Day. We hope you enjoy the day, whether you're already in research, starting out, or completely new to research. Please stay tuned. We have got quite a jam-packed day, and hopefully there is something for everyone to enjoy. So stay in room 6. Just before we get started with the first session, that will run between 9 and about 10:30. I've just got a little bit of housekeeping information I have to give you. So I'll just pop on the housekeeping slide. Super, thank you. Firstly, I just want to say a huge thank you to the whole of the SCTS Nursing and AHP Research Subcommittee, just in helping putting together today's programme. But a special mention does have to go to Rosalie, who has certainly taken the lead and has spent an extensive amount of time, blood, sweat and tears, I would say, into today's programme. And without her hard work and dedication, this wouldn't be possible. So a huge thank you to her. Secondly, as this is our first ever SCTS Nursing and AHP Research Day, please just bear with us. We're not using the same platform as the main meeting, Shocologic. So as you're aware, we're on Zoom instead. There may be a few glitches along the way, so we do apologise, or if there's moments of silence or any technical issues, just bear with us. We will obviously try and avoid it as much as possible, but it's our first one, so who knows. But on the back of this, as it is our first day, we would welcome any feedback. We'll be encouraging you throughout the sessions to give us feedback throughout the day, and Rosalie will remind people as well to give us any feedback that you have on the day, because this will help us understand what you want for next year's conference, but also obviously improve any future conferences going forward. We will be recording the sessions and people will be tweeting throughout the day as well, so there'll be information on the social media platforms as well. Lastly, after each speaker, there will be a chance to ask questions. So after each speaker has finished, there'll be about a 5-minute question session. Please send them via the chat, and I'll collate them throughout the session. But after all of this speakers have finished for that session, what we're going to do is do like an open question and answer session, and that'll be for about 20 minutes. And so we'll open sort of the floor out to the people to ask any questions, and for the speakers to answer them, but also people can also answer them themselves as well. If for any reason you don't see your question, it might be that we'll just wait until the end, because it might be that actually that question could be more appropriate for everyone to answer rather than just one speaker. So if that is the case, don't worry, we will get around to asking your question. If we do finish the session early, please take an extra break, make a cup of tea, go to the toilet, etc., or head to one of the other sessions of the University Day. There is obviously the other 4 or 5 rooms to go and enjoy as well. But just make sure, excuse me, you come back to room 6 after you've been there and come back. So our session will run, like I say, 9 till about 10:30, and the next session will run about 11 till 12:30, and then session 3 will run about 1:30 till 3. And then if you have signed up to the speed mentoring, that will start about 3:30 till 5. So now the housekeeping out of the way, let's start session 1, which our first session is looking at nursing and AHP research within the cardiothoracic surgery and updates from the SCTS and CIRRN, which is the Cardiothoracic Interdisciplinary Research Network. So our first speaker is Professor Julie Sanders. She is the Director and Clinical Researcher at St Bart's Hospital, home to one of the largest cardiac centres in Europe, and Clinical Professor of Cardiovascular Nursing at Queen Mary University of London. She has a range of clinical research and clinical research roles throughout her career, and now focuses on developing research and clinical academic career opportunities for nursing and allied health professionals at St Bart's Hospital, and pursuing her own research in recovery for cardiac surgery. Julie is also the SCTS Nursing and NAHP Academic Lead, ESC, ACNOP, Treasurer and Secretary, NIHR Senior Nurse and Midwife Research Leader for London and South East Hub Facilitator, and the RCN Research Society Steering Committee Member. The floor is yours, Julie.
Thank you very much. Good morning. I hope you can see and hear me okay. I'll wait for a thumbs up from Rosalie. Excellent, thank you. Well, it's a real pleasure to be speaking first today on our very first Nursing and Allied Professional Research University Day. And thank you very much to Zoe for such a warm welcome and to explain how the day will work. My job is to really set the scene this morning and to highlight to you what research opportunities there are, what we've been doing, and why research is important. So there we go. So the plan really is to look very briefly at the importance of developing cardiothoracic surgery research. We'll have a look briefly at what the UK cardiothoracic research priorities are, so that you're aware of which themes and which areas are particularly important at the moment, and also what work that the SCTS Forum and the Research Subcommittee are doing to support nurses and allied professions to both do, facilitate, support and use research in practice. So often research is something that kind of baffles people and they're a little bit scared of, and they think that actually, what is it? And it can be easily misinterpreted. Obviously, we're all a little bit biased and we think research is wonderful, but we'll try and make it as, what we want to do is to make research as open and accessible to every member as possible. So the importance of developing research, as you know, research active trusts have better patient outcomes. And so what we want to do is to make research part of business as usual. Hospitals that have high research participation rates have improved patient outcomes and survival. And we also know that patients have more confidence in staff and are better informed about their conditions in hospitals that do a lot of research. From a nursing perspective, we also have evidence to show that those who value and use it are more likely to use research findings in practice. So it really is important that we become much better at integrating research into part of our everyday work, and we don't consider it as a bit of an add-on or things that only certain people might be interested in progressing. Within the UK, certainly we need to be defining the role of surgery, and that all of that is dependent on having high quality research. And it won't surprise you to learn that the UK actually produces 15% of the world's top rated scientific output, but we actually only have 7% of the world's researchers. So we're quite small in terms of our capacity to do research. And if you look certainly from a medical and a surgical perspective, if you look at our medical colleagues, there are actually more cardiothoracic academics in Leicester than there are in the rest of the UK put together. So we really do need to be expanding research, not only in our surgical colleagues, but also in nursing and allied health professions. Because actually, if we think about how little there is in comparison within the surgical field, there's even much less in the nursing and allied profession field. And there are very few senior researchers from our professions. So one of the things we want to do is to make sure that we can offer some national and local opportunities for nurses and allied professionals to engage much more in research. And hopefully in the future, this will be supported by an increased investment in life sciences. And this hopes to increase the number of clinical trials funded in the speciality by about 50% in the next 10 years. So there's plenty of opportunities. So what we need to be doing is really harnessing those and making sure that we're fully prepared to take those on when they come. So it's a Sunday morning. I don't expect you to read this slide. There's lots on it. But what I do want you to just take away is how many of those purple arrows there are. So what the table on the left shows is the classification of each of the levels of the guidelines that are included in the Enhanced Recovery After Surgery Society recommendations, specifically for cardiac surgery. And there are about 21 of those. But you'll see there are about 7, so about a third of them are indicated by a purple arrow. And these are the ones that have low levels of evidence. So we have a guideline where about a third of those guidelines are made up on relatively low levels of evidence. And as you'll see from the text slightly more on the right-hand side of the slide, these are about stopping smoking. There's some in some of the diabetic management, some of the nutritional control, and quite a number of areas that perhaps would be very interesting and pertinent for nurses and allied professions to be looking at. Specifically, say from a physiotherapy perspective, there are aspects of prehabilitation, for example, that really we don't have very much evidence on at all. So there are guidelines in existence where we can definitely be building on the research and certainly would have impact on us professionally. But also, in 2018 and 19, we underwent a process where we defined the UK cardiothoracic research priorities. I'm going to tell you just a little bit about that process and also the outcomes so that you are aware of what the research priorities in the UK are. So the process of defining research priorities is led really by the James Lind Alliance. And they have a real philosophy about addressing uncertainties, about treatment effects, etc., so that they become part of routine clinical practice. This is very much what we've been talking about so far this morning, is that research becomes part of everyday business as usual. But how you come to define what that priority is about patients, carers, and clinicians working together to agree what those uncertainties are. So where we have low levels of evidence, but what matter most and therefore deserve priority, both from a funding and a research perspective. So again, this is the process. It's quite a busy slide, but again, the key points of this process are that it really does integrate patients, carers, and healthcare professionals in the process of identifying the priorities. So the top purple arrow indicates specifically where you ask patients, carers, and clinicians what their priorities or what their questions they have for research. And this is usually done in an online survey. You then collate all of those responses and you check them against the evidence and the literature to make sure that they haven't potentially already been answered. And if they have, then they don't become an uncertainty. You then generate from that list a long list, if you like, of priorities that people have raised the questions and there isn't any evidence to answer them. And that long list then goes back out to patients, carers, and clinicians, again, usually by a second online platform and survey, where they're asked to rank. Everyone's asked to rank what they consider to be the most important. And often you'll get to ask them to rank their top 10. Once those come back and you've maybe got the highest kind of 25 or so questions that everybody together has put together, you then have a workshop. Again, mixed of patients, carers, and healthcare professions to identify what those and discuss and finalise what those top 10 research priorities are. And the impact of having those top 10s is that they inform funding bodies which areas are more likely that they should fund, and obviously provide researchers with key direction of what they should be looking at. So in terms of cardiac surgery, this is the process. So it started back in February 2017. We obtained funding from Heart Research UK. And the first survey, so that first survey where people identify their research questions, actually was launched at the this annual meeting back in 2018. That survey generated 1,080 questions by 629 participants. And all of those questions were then checked against the literature. They combined duplicate questions, etc. And a total of 49 summary questions were identified. Those 49 questions went back out to a second survey, which was launched again at the annual meeting in 2019. And if you remember, that's the one where people were asked to rank their top 10. So that ran until June of 2019, and there was 492 participants, which led and narrowed down that to 21 summary questions. And those 21 summary questions were then discussed at that final workshop in July 2019, and we got our top 10. And so these are our top 10 research priorities for cardiac surgery: quality of life, frailty, chronic conditions, prehabilitation, heart valve intervention, surgical methods, organ damage, 3D bioprinting, atrial fibrillation, and infection. And a lot of these will be updated throughout the meeting this year. So do please look out for them. And they again have been published, and the funding bodies have been made aware of them. And there are work streams going on in each of these areas. So we've got our research priorities. We know that we want nurses and allied professions to be more engaged and have opportunities to engage in research. So what have we been doing so far as part of the SCTS forum to enhance and make people aware of what those are and how they can get engaged? So our vision is really to be able to encourage, promote and assist in the development of clinical academic careers and research opportunities in cardiothoracic surgery in the UK. And as I mentioned earlier, we have a fab research forum subgroup of whom you'll meet everybody, I think, today during the course of today. And so we're all working on different parts in order to bring this together. So you'll hear from Sean and Lyral later about the directory. Rosalie is obviously our magnificent host today, who has organised today. Tracy and Ashley are both moderating later on, and Zoe gave us an exceptionally warm welcome this morning, and has been really instrumental in setting up our website, which you may have been aware actually launched a couple of days ago now. So we're working to do a number of things, and as you can see, we'll be relatively kind of busy. We have here particularly in purple, our kind of research networks. So we have the Cardiothoracic Interdisciplinary Research Network, which I'm not going to talk a lot about because Ricky, who follows me today, will tell you much more details about that. But that's effectively about getting people engaged and supporting trials in their local hospitals. We have the Nursing and Allied Professional Research Group, the NAHP, which is a directory which Sean will talk about a little bit more as well, of and a database of those of you who are interested in research at all levels. So we don't say you only have to be at a certain level. So whether you're interested or an experienced researcher, you're very welcome to join the NAHP. And what we do is provide a lot of information and opportunities through there. As I say, we have an email and a directory coming through. We usually have sessions at 2 meetings. This one, the annual scientific meeting, we usually meet. And as I say, this is our very first kind of formal university day, which we really hope will be successful and that you will gain something very positive from it so that we can offer it on an annual basis. And we also have a group meeting at the National Research Meeting, which is always held in November. and this year it will be on the first Saturday of November, so please save the date in your diary. We equally, as I mentioned, have a new website and the SCTS bulletin. We always put updates, and I'll show you a little bit more about those in a bit. And certainly moving forwards, we have webinars and, as I say, this University Day, which we hope to introduce and take forward. So there are a number of initiatives that we're doing, some which are being updated currently and some which are very new that we'll be taking forward from today. So I'm going to focus a little bit on the research day, a small amount on CERN, and the directory will come up later. But if you're interested in joining the NAHP, which was established initially in 2017, then please do email us at the address on the screen. As I say, it really is our first step in creating a community of those that are interested in cardiothoracic research, and also to be able to encourage and support the development of nursing and allied professional-led research, to share our expertise and to highlight research opportunities. So please, at all levels of your interest, please do join. We launched and we have a nice community of about 59 or so members now, which is really great for networking and providing support. We have a list of those people which will become in a directory, which, as Sean will highlight later, will be much more expanded as we move forward. And with our new website, we hope to provide an expanding online research resource library, of which we will also include details of and report on relevant research events. So just to highlight where you'll find these bits of information from us. So as I say, we always present at the meetings and the SCTS National Research Meeting. So we have 2 opportunities per year to come together, which is really helpful and beneficial. We also put an update in the bulletin each time, so you may have seen it. Sometimes it's about the research projects that we have been developing, and more recently it's about the updates of the CERN, and also we have begun to include work that Tracy and Ashley have been doing and leading on, which specifically looks at highlighting some research from a nurse or allied professional, do a bit of a research roundup, and also an interview with the researcher, which we'll also put on the website as a podcast. So you won't have to be reading papers galore, but we'll provide the information to you, hopefully in small, bite-sized and easily digestible forms, which hopefully you'll get something very useful out of. And these are relatively new. We've done these for the first time this year, and the podcasts, etc., will be on the websites very soon. We have plans to do webinars in between the 2 national meetings so that we can keep engagement going, but also focus a little bit more on very specific topics. From the national research meeting last November, and for those of you who were able to attend, we had quite a discussion about what things would be very useful. So we're going to do a clinical academic careers webinar, which will be in September, and an evidence-based practice one that will be in February. But we're really open to other suggestions as to what would be most helpful, and please do feel free to email me with any suggestions that you may have. So how can you find out more and get involved yourself? So in terms of this meeting, we've got a number of presentations that you may be interested in. So I'm sure Ricky will mention these in his presentation, but the work that the CERN have been doing relating to surgical site infection is both being presented in a poster and an oral presentation on Monday and on Tuesday, respectively. And I'm doing a presentation on Tuesday about a visit that I recently did to Toronto to look at how we can increase research opportunities for nurses and allied professions. Please do join the NAHP, and you can access that application through the SCTS website or email directly at the SCTS admin email address. And equally for the CERN, if you're interested in taking part in that, we have a representative at each hospital, but we're always looking for more nurses and allied professions to join. And as I say, you'll get more information on this from Ricky very shortly. But again, do feel free to email me directly on that. And please do follow us on Twitter too. So that's the update from me. I'd like to say thank you very much indeed for attending and listening at this time on a Sunday morning. And please do feel free to contact me, as I say, and to follow me on Twitter, where I also put a lot of kind of opportunities and things that can easily be shared. And I very much look forward to working more with all of you in the future. So thank you very much indeed for your attention.
Brilliant. Thank you ever so much, Julie. I definitely agree. Nursing and AHPs do have a real place within research, and it's definitely getting bigger. And it does look like everyone at the SCTS research subcommittee has definitely put in a lot of hard work. So it looks great. So we do have quite a few questions come in. I think one of the big questions are, and maybe we'll open this up again later as well, but Julie, your thoughts on sort of what are the challenges getting nursing and HPs into research, I suppose from maybe an employer, but also an employee's perspective?
It's a really good question, and one that I'm asked quite frequently. I think the challenges also depend on where you are. So often having a really good champion and someone that can support you is a key thing. Well, and I personally don't sign up to the fact that it has to be a nurse or an allied profession that supports and champions another nurse or allied professional. I personally was always championed by surgeons and intensive care consultants, and that's how I got my opportunities. So I think the key is always to find a champion, whoever that may be. If you're interested in going more in supporting the trials work, which Ricky will talk a little bit more about, that can be a little bit more straightforward in some ways, because they would be trials that hopefully your centre would be wanting to engage in anyway, so you can gain some experience. If you're wanting to do a clinical academic career, then one of the things you need, that champion, as I say, but you need probably someone to advise you on your career trajectory and where you want that to go and what avenues, because even if you follow a clinical academic career, the path doesn't have to be the same for everybody. And so I think finding somebody that will be able to support you in that decision-making process is quite important. And that's a lot why we're doing the directory, which Sean will talk about, and why we're doing the speed mentoring in particular. So those types of conversations are usually very good for those types of things. And so if people feel that actually doing more speed mentoring, where you can access myself and others that have done PhDs and gain maybe a little bit more one-to-one career development and research guidance, then that would certainly be something we'd be very happy to do. And please do just kind of let us know if that's something that would be very beneficial.
Brilliant, thank you, Julie. I think on the back of that, a lot of people ask about these things. How do you get your managers, your sort of seniors, matrons, etc., to buy in to you, to have protected time for research, etc.?
So depending on where you are in your clinical academic career, it can be easier or not to persuade. We certainly at St Bartholomew's Hospital have been able to demonstrate the value of people engaging in research. And so on the back of that, we kind of have a bit of a snowball effect now. What that does mean is that we have some really good case studies that we can help others, maybe in other hospitals that maybe don't have others that have trod that path themselves yet. And maybe you're being the trailblazer for your institution. And quite a few of the funding streams, particularly for PhDs and beyond, actually pay for your clinical salary time. So actually, if you're seconded out, the organisation doesn't lose out financially by supporting you, and that can often add really good opportunities for others to gain experience maybe in your role. So you kind of have a catalyst of being able to support other people. So I think there are different mechanisms, but certainly being able to demonstrate the value both to you personally but to the organisation as to what you'll be able to achieve by engaging in research is a good place to start. And we can provide some practical examples of how it has worked and how people have been supported, which sometimes I think can be helpful. Most people are usually just a little bit cautious if they've never had to do it before.
Brilliant. Yeah, I think I agree. It's quite hard to, if you're new into research, to get your managers your line managers to get behind it, especially even if there is that backing. They are going to lose you as a clinician for a little while, but it's just making sure that they're aware of what the benefits are going to be for you conducting that research, being sort of, what you're going to bring back to the team. I think the other thing, we're going to have lots of probably people here today that are really new into research, so maybe going down sort of doing studies and PhDs is sort of a long way off. What would you sort of suggest to your more junior members of staff and people wanting to engage in research that are very, very new to it? How would you what would you sort of advise them to do?
So I think there are a few really straightforward things that you can do actually to get a little bit more exposure. One is that most hospitals are likely to have a research nurse delivery team. So those are the research nurses that are employed to deliver the clinical trials. And you can do some work experience kind of type things, some shadowing, learning about how the trials are set up, how to consent patients. If you work in a clinical area or a ward where those trials or studies are being conducted, you could make yourself known to the principal investigators or the chief investigators and ask how you might be able to help from a clinical perspective. So often real challenges for researchers are identifying the right patients when they're coming in, when they're maybe having their procedures, etc. And you could be a real conduit in terms of helping to facilitate the research delivery and start building up some experience and exposure to research that way. So I think find out who your key kind of researchers are, both from a nursing and allied profession perspective, but also from your surgical team or other teams, actually, if you don't have a surgical team to work with per se, but you can start doing those things that don't necessarily mean you have to take time out of your clinical area, but actually can support the engagement of research in your clinical area to the good of everybody.
Brilliant. Thank you ever so much, Julie. There's a few other questions sort of coming in, but I think we'll wait till the end of the session when we open the floor up to get the other speakers maybe to answer a few of them as well, if that's okay.
Perfect.
So thank you, Julie. So our second speaker of the day is Ricky Varga, who is going to talk about the updates and current projects going on with the Cardiothoracic Interdisciplinary Research Network. Ricky is a British Heart Foundation Clinical Research Fellow and Associate Surgical Specialty Lead for Cardiac Surgery. He also co-leads the Cardiothoracic Interdisciplinary Research Network. So Ricky, the floor is yours.
Sorry, there we go. Can you hear me now?
Yeah.
Excellent. Sorry, can you see the slides?
Yeah.
The screen, fantastic. Well, good morning, everyone. Just wanted to say thank you very much for inviting me and giving me the opportunity to come and talk to you today. So my name's Ricky. I sort of co-lead the Cardiothoracic Interdisciplinary Research Network, along with some of my other colleagues whose names are up on the screen. So I'm giving two presentations today. So the one is on the update about the Cardiothoracic Interdisciplinary Research Network, and the second one is about the Associate PI scheme. But what I'm going to do is I'm just going to flip the order of the presentation. So what I'll do first is talk a bit about the Cardiothoracic Interdisciplinary Research Network, who we are, and the Associate PI scheme, and then I'll finish off by discussing our current projects. Excuse me. So we've briefly heard from Julie earlier today that we know that defining the role of surgery is dependent on high quality research. And we know that UK produces some of the world's best scientific research, especially in cardiothoracic surgery, with only a small number of researchers present. We've also heard that there's going to be an increased investment in life sciences and a 50% increase in funding of clinical trials in the next 10 years. So in order to stay ahead, there's a number of things we need to do. Number one, we need to form a collaborative research network that can try and deliver a portfolio of clinical trials. Collaborative research is not something that is new. It was first founded in this country by the West Midlands Research Collaborative, and this was over 10 years ago. And they've really grown from strength to strength. So for those of you that don't know, the West Midlands Research Collaborative is a collaborative in general surgery. And this last year alone, they received over £10 million worth of funding to deliver clinical trials. And their research collaborative primarily involves surgical trainees. So these are mainly revolves around doctors within this research network. But collaborative research is not something that is new to cardiothoracic surgery. So the CTS net was founded in America and Canada, and this ran over about a period of 5 years, and they received over $50 million worth of funding. And they had two principal investigators, so a cardiac surgeon and a cardiologist. And they ran over a number of sites across North America. And traditionally, there's been a history between a lot of fighting between cardiologists and cardiac surgeons, but rather than actually fighting with each other, by working together, they were able to go from the previous picture to this, and as a result, they were able to produce this. So numerous publications in the New England Journal of Medicine. And what's interesting to note is that remember they had 34 centers involved in their research collaborative. And actually only one of these papers had more than 2,000 patients recruited. If you just imagine in the UK alone, we perform over 35,000 cardiac surgical procedures every year. So just imagine what we could achieve if we work together. So how do we stay at the forefront of research? So we've briefly heard from Julie about the research priority setting partnership and the top 10 research priorities. There's also been the appointment of the associate surgical specialty leads and the establishment of the Cardiothoracic Interdisciplinary Research Network. The SCTS vision is to really create a community of NAHP cardiothoracic researchers to encourage and support the development of research in this specialty. And the Cardiothoracic Interdisciplinary Research Network, this is the first ever network that is truly fully interdisciplinary. And the plan is to have, for each cardiothoracic surgical site in the country, to have a number of NAHP members, and each site will have a nursing or an allied health professional member. And the idea is that when clinical trials are set up locally, each of these centres will have various representatives, and that will hopefully help try and facilitate and deliver a number of clinical trials across the country. And we think having this interdisciplinary research network is a great way to engage cardiac surgery research and build capacity and capability in the specialty. And really, on the previous slide, I showed this photo about the cardiologists and the surgeons working together. But actually, at each of the centres, it's not the doctors who deliver the research. It's actually you guys. It's the nursing and allied health professionals. So really, we want to build even further. So we want to go from this to actually this. It really is a team effort, and we need everyone at each of the centres involved to be able to really deliver high quality research. And a bit like the Avengers, it's really important that everyone is recognized for their work. So one of the key things for the Cardiothoracic Institute Research Network is that we adopt something called corporate authorship. So it means that all of the work is published under this group or corporate name, and all individuals involved in the project are named in the appendix, and people who have had a significant contribution will be named authors on PubMed. And this allows for flexible roles within the research network. So for example, in one project, you may want to take a bigger lead. And for other projects, you might want to take slightly a backward step. So it just really allows for everyone to be involved, whatever time, depending on whatever time commitments you have. This is an example of the ways we've used this corporate authorship. So on the left here, this is one of our the first publication. So this was a collaborative publication with NCBC and Public Health England, and this was published in the Journal of Hospital Infection. And we've got another publication which is currently in press, and this is a collaborative piece of work with the COVID Surge Collaborative. So now I'm just going to talk a bit about the associate PI scheme. So we've mentioned that often what happens in centres is you have a PI, which is traditionally a doctor, and actually at each of the sites, it's the more junior members of the team, so that could be either doctors or allied health professionals, or even senior members of the team who aren't the PI, who often do a lot of the groundwork, but don't get any of the recognition. And the associate PI scheme was set up by the West Midlands Research Collaborative, and essentially it aims to ensure that everyone who contributes to research really gets the recognition that they deserve. And initially it was to be an associate PI, you would need to be a doctor, but Professor Julie Sanders has worked really, really hard over the last few years. And as a result, now an associate PI doesn't just have to be a doctor, it can also be a nurse or a allied health professional. And essentially the idea is to not only ensure that everyone receives the recognition for the research, but it also allows these associate PIs to develop some sort of training and mentorship, and allow them gives them a platform to become PIs of the future. And the plan is for each clinical trial that is delivered in the UK in cardiac surgery, in addition to having a PI at each site, there will be an associate PI, and these will be members of the Cardiothoracic Interdisciplinary Research Network. So how do you join the scheme? So essentially, first of all, you need a clinical study. And if there is a clinical study happening or clinical trial happening in your centre, the first thing to do is check, is it registered? So you might want to approach either the local PI or the chief investigator and find out if they are registered. If they're not registered, you can have a discussion with them and try and get the study registered on the associate PI scheme. Next step is to then register yourself. So to be registered as an associate PI, you need to prospectively register. So it needs to happen whilst the study is ongoing, and it's not something that you can retrospectively do. Finally, you complete a checklist, and then once that's been signed off, you then receive your certificate. What I'm just going to do is just quickly show you what the certificate looks like. Can you all see this? Can you see the checklist? Yeah. Yeah, so this is an example of the checklist. So what happens is you need to demonstrate to the NIHR that you've been involved in all stages of the research process. So you need to log things like how much involvement you've had. So it involves things like, have you presented the work or disseminated, not even the findings, but to raise awareness of the work to your department, others in the area, to try and boost recruitment. So you have to try and log all of these things. Have you engaged regularly with the PI and the rest of the research team? So if there are steering group meetings locally, logging where and how you've been involved with them. Have you been involved in consenting patients, so documenting how many patients you've consented and recruited to the studies. Also any other research activities that you've been involved with. And then finally, once you've written down all of these, whatever you've been involved in, at the end of the study, what will happen is you then go to your local PI, they will check through your checklist. If they're happy, they will sign this off. as well as the local study coordinator. And then this is then submitted to the NIHR. They will then look at what you've done, and if they deem that you've contributed enough, they will give you a certificate that shows that you were an associate PI for this. And that's really beneficial because it goes on, number one, it goes onto your CV, but number two, if in the future you're applying for an NIHR grant yourself, it looks really good on your portfolio that you've had a history of being an associate PI, and it would potentially improve your chances of successful funding. Just go back there. Perfect. That's the end of the first section. So maybe we could just pause here, and I'm happy to take any questions for the time being before I move on to the next section about the ongoing studies.
Brilliant, thank you, Ricky. I think we've got just a couple of questions. What are the skills that we need to develop in order for us to become associate PIs in the future?
So in terms of becoming an associate PI, all you really need to do is do your online GCP training, which is on the NIHR website, and that's a prerequisite to be involved in any research. And apart from that, there's not much else really. What you need is to make sure you've got the local PI on board, and it's almost like a mentorship scheme. So it's an opportunity to learn how research is conducted. So in the first instance, you might be completely new to research. So it might be a case of you working with the whole local research team and the PI, understanding the whole process of how to consent patients, how to recruit patients to trials, what exactly happens, what paperwork needs to be filled in, and then slowly taking that board and learning from that process. So apart from needing GCP, there really isn't much more than that. So anyone can really be involved, and it's a learning opportunity. Yeah,
great, Ricky. I think definitely being an associate PI doesn't have to be a medic. I think it's great for the nursing and NAHPs to get our professions sort of back on the map for research. That's brilliant. Do you want to move on to your next presentation?
Yeah, sure, absolutely. Thanks, so we heard earlier from Julie about the top 10 research priorities. So she's mentioned the 10 of them here, and as some of you may or may not be aware, myself and Luke Rogers, who's one of the other associate surgical specialty leads, we were allocated to be moderators and sort of co-leads of research priority 10. So essentially, how can we reduce and manage infections after heart surgery? So this includes surgical site infections and pneumonia. So I know what you're all thinking. This isn't a picture of me in theatre taking a mammary. This is actually a picture of Denton Cooley performing one of the first coronary artery bypass operations. And what's staggering is something that you won't see today, is the number of people in theatre today. But what's actually more impressive is that every single one of these the people in theatre is actually wearing a mask. And I don't know how many of you have been in and out of theatre, but how often does everyone in your theatre wear a mask? And so this is sort of this image is sort of helps form the basis of our research question, and a bit about surgical site infections. So we know that surgical site infections, the majority of these are actually preventable, and actually they do have a really significant impact not only on mortality and morbidity for patients, but also it can affect the lives of their loved ones and their carers. It's really expensive. It costs the NHS over £15 million a year. And the incidence of wound infections after cardiac surgery ranges somewhere between 3 to 10%. There's a lot of clinical uncertainty as to what the best practice is. And there's also an increasing concern around antimicrobial resistance. So we've heard that reducing wound infections after heart surgery is a national research priority. So the next step in trying to address this is we wanted to find out what the current evidence is and to try and establish some knowledge gaps. So what we did is we set up a team and we conducted a Cochrane systematic review. And we looked at over 100 randomized controlled trials, and we essentially identified 22 interventions where there was some evidence for. And what the interesting thing was, the actual quality of the evidence in the literature was really, really, really poor. And it's actually unsurprising because there are currently no national guidelines in cardiac surgery in terms of interventions to reduce wound infections after heart surgery. So from this Cochrane review, we'd identified various areas of knowledge gap. The next thing to look at was what people are doing across the country. So we wanted to look at the variation in practice. And what we did was we teamed up with NCBC and Public Health England, and we sent out a national survey. So in the end, we had 19 centres included, and we established to look at the routine practice of 145 consultant surgeons. And this work showed that there was significant variation, not only between what different hospitals are doing, but also between different surgeons within the same hospital. And using all three of these bits of information, the plan was to apply for an NIHR program grant for applied research. And we developed a research question. So our research question was, will using an SSI risk prediction tool to administer personalized SSI prevention interventions to people undergoing cardiac surgery be superior to existing standard of care in relation to SSI rates, antimicrobial resistance, and cost effectiveness? When trying to design this clinical trial, we came across three barriers to the successful delivery of a randomized control trial. And before proceeding, we decided to try and address these barriers in three separate work packages. So number one, although there are a number of risk prediction tools that are currently used, we wanted to look at the different risk prediction tools and try and develop a risk prediction tool that had the ability to discriminate between different levels of risk of SSI. We also wanted to know what was usual care, and we wanted to know why certain interventions are easier to implement in some centres than others, and to try and identify some of the barriers and facilitators to that. And then the final thing was to know was to understand what were the barriers to accurate surgical site intervention surveillance. So the first package, which is being co-led by Dr. Penny Whiting, who is from the University of Bristol, and she's an expert in sort of complex systematic reviews, and she's written a lot of the guidelines in terms of how to run some of these systematic reviews alongside myself and Luke Rogers. And the plan is to perform a systematic review where we will look at all risk prediction tools in all clean surgery. And the plan is to try and identify what variables go into some of these tools, and then to try and look at compare the different risk prediction tools across different surgical specialties, but specifically in cardiac surgery. And one of the limitations for a lot of the risk scores that are currently used is they're based on retrospective data analysis. So they sometimes don't capture things like health inequalities, failure, but also some laboratory derived predictors such as iron status, HbA1c, vitamin D. And the other issue is there is a variation in terms of the definition of SSI use. So some of the different risk prediction scores sometimes use non-standardized SSI definitions. So it can become very difficult to then compare the different risk prediction models. And so the plan would be to conduct this systematic review and then try and identify these predictors, which we would then enter and develop a new risk prediction tool that can be used for cardiac surgical centres. And the plan was within 18 months to complete and publish a systematic review and identify these potential predictors that we will then use in a prospective observational study. The second work package is led by Professor Judith Tanner in the University of Nottingham, and it's to try and identify these barriers and facilitators of SSI interventions. So what's going to happen is this is going to be run across 4 sites, and the plan is to generate a process map to identify what usual care is and in the context of these SSI interventions. And the eventual plan is to try and develop strategies and tools that centres can use to try and maximise compliance for these interventions in the future clinical trial. So again, as I mentioned, this would be run across 4 centres, and the plan is we will have a researcher who follows of 32 patient journeys from the preoperative assessment towards discharge. In addition to that, they would also interview staff across the 4 centres to try and find out a bit more about the day-to-day work. One of the really cool and novel things about this piece of work is we're actually going to get a patient, a member of the public. We're also going to train them up as a researcher, and we're going to get them to also follow the patient journeys. And the reason for this is that we think what a patient may observe will be completely different to what a researcher or a clinician may observe. So we hope this will give us some novel insight into why certain interventions work better than others. The researcher will also be involved in the data analysis and the further development of the work. And as mentioned, the key output would be to develop a number of checklists and strategies to try and maximize compliance. And finally, work package 3 is being co-led by Melissa Roach and Catherine Vlock, who is a scientist who works for Public Health England. And essentially, Public Health England undertake SSI surveillance, but not all hospitals contribute to Public Health England surveillance. So the idea is to try and work out why some centres partake in surveillance and others don't, and to try and improve or increase the number of centres who contribute to SSI surveillance. I'll just skip through these slides. And the key output is to try and maximize the number of centres who contribute to surveillance. And one of the novel things about our future clinical study is to try and use the routinely collected data that Public Health England already collects as part of one of our primary outcomes. So the future work, the plan would then be to, once we've addressed some of these barriers, is to then apply for a large programme grant for applied research. And as part of this, there are going to be two things that we're going to do. So number one is going to be an observational study. So this will be a prospective observational study where we essentially try and develop a novel SSI risk prediction tool. And then finally, we will undertake a multi-center randomized control trial. So the plan for the observational study, this will run over the space of 2 to 3 years, and it will be hopefully most of the centers in the UK. And the plan will be to use routinely collected data, so things like Public Health England data, NICOR data, and we will work with the BHF Data Science Centre to try and link the different data sets together. And essentially, our primary outcome is Public Health England definition of SSI within 30 days. And what we'll do is we will look for predictors of of SSI that we've highlighted in our systematic review in work package 1. And then we will use regression analysis and machine learning to try and develop a personalized risk prediction tool. And once we've developed that, the plan would be to then run a randomized control trial. And essentially what we want to do is we want to look at whether or not interventions like chlorhexidine and decolonization and gentamicin sponge in the wound can potentially reduce wound infections. And the idea is, and at the moment, there's no guidance in terms of which patient should be receiving this. And so the idea is, if we target who we give these interventions to, so if we just give them to the highest risk patients, that hopefully should be non-inferior compared to just giving it to everyone. And we hope that this would be not only cost effective, but potentially also reduce antimicrobial resistance. We think we will probably need around about 5,000 patients, around 2,500 patients in each arm. So this will potentially be one of the largest clinical trials in cardiac surgery to date. So it will be really important that we get good engagement from every single centre. And we really need everyone involved to be able to deliver this. And in addition to the clinical trial, dissemination, engagement and implementation is also really, really important. So throughout the whole process, we're going to run a number of webinars, and we want to work with the centres as we go along. So keep an eye out for for the different webinars that are coming up. And I'm pleased to announce that we were recently awarded a program development grant to deliver the first part of this work, and we're due to begin this in September 2021. As mentioned, a lot of these studies are going to involve surveys and interviews at each of the cardiac centres in the UK, and we need local representation, so we need local leads to try and develop this. So please do get in touch. Our email will be at the end of the study, so please do get in touch. There will be ample opportunity over the next few years. Just a few of our other projects that are ongoing. I forgot to mention earlier, so Julie mentioned about the top 10 research priorities. So what we've done is we've ensured that we've now got at least one CERN representative in each of the research priorities. And if one of those research priorities is something that you are interested in and want to get involved in, please do get in touch, and I can try and put you in touch with the relevant person to try and get involved with this. And it's a fantastic opportunity because you get to really be involved in a very large research project from the outset. You get to sign into the steering group meetings and really learn how you develop a research question, how we then work this into a grant application, and then the subsequent delivery of a clinical trial. But in addition to the clinical trial work, we've also got a number of systematic reviews going. We've got a Cochrane review ongoing looking at antithrombotic agents and following CABG. And again, we've got a multidisciplinary team delivering this. We've also got a pan-surgical systematic review. So this is working across different surgical specialties, looking at vitamin D replacement and surgical outcomes. And also, we're also looking at supporting a number of clinical trials within the UK. So again, please keep an eye out. Just on a note, so tomorrow we've got a patient and public engagement webinar series. So if you are available, please do sign in. It's between 11 and 12:30. And we've actually got patients who are delivering the presentations themselves. So it should be really exciting. So in terms of the future, we've mentioned the program development grant, and actually the plan is to really have a large portfolio of clinical trials that are delivered by the Cardiothoracic Interdisciplinary Research Network. So please do get involved. And our vision is to try and deliver high quality cardiothoracic research that impacts patient care. The days of single center research are slowly fading away. So it is really, really important. The only way that this can work is if everyone contributes and everyone gets involved. And remember, together, everyone achieves more. So thank you very much for your time, and I'd like to welcome any questions.
Brilliant. Thank you ever so much, Ricky. I think it's Sunday morning, so everyone's just been a bit quiet on the question front. There's a few things that have come sort of repeated and I think you've answered parts of it about how can people get involved with like the different work packages that you were talking about. What's sort of the easiest way to be involved?
So I guess the first thing, maybe just drop us an email, so network at outlook.com. So do drop us a network, or drop us a tweet, send us a message, and then we can have a chat with you. We can find out what your level of experience is, what level of involvement you want to have, and then we can try and put you in touch with the relevant team. And also, if you have a research idea yourself that you want to develop a grant or something, and you want a bit of support from the research network, again, do get in touch, and we can offer different levels of support depending on where you are.
I was going to say, because I think that was sort of the next thing people ask, don't they, is what level of experience do you need in order to be involved? And by the sound of it, sort of you can be at quite a variety of stages in order to help.
Exactly, yeah. So, for example, we've had some people who really want to get involved in research and have never been involved in research. So we might introduce them to something a bit more introductory. So maybe like being on a systematic review team, helping develop the protocol and those kind of things. Or we've had, for example, someone came to us with the idea of this vitamin D replacement. So we've sort of helped develop sort of the protocol, deliver the systematic review, and then the plan is to try and help support a grant application for a clinical trial. So as you said, there's various levels that you can come into. So whatever your level of expertise, we can try and facilitate that for you.
Yeah, and I think that's really great. And if you don't mind, people, you might be bombarded with questions and more information. So that's great, Ricky.
Absolutely,
I think
no worries.
there was a couple of someone's just put about they've recently read about the development of the BART surgical infection risk. So the BSIR tool. What would be the difference between your work and this existing tool?
So we're not. So at the moment, there are a number of risk tools. So I know BARTs have one. There are a number of hospitals that have a risk prediction tool, and some of them have, definitely there's evidence to show that they do reduce wound infections, and then trying to target infections to try and reduce that. What we want to do is to take a step back, and in the first instance, we're going to do this systematic review. So we want to look at all of the different risk scores, and the plan is to try and have an unbiased approach. And a lot of these risk scores haven't been developed using prospectively collected data. And as I mentioned, they may not look at things like health inequality or some of the blood test results. So we want to try and use clever things like machine learning to see if we can develop a more accurate risk score. But at the same time, what we will also do is we will look at the existing scores. And if these existing scores are better or are better than the one we developed, then there's no reason to not use that existing score. But what we want to do is look at all of the different scores and then try and come up with a score that all of the, each centre can use.
Brilliant, thank you, Ricky. A few people have been saying, how do they contact you? Are you happy with the email that's on the screen at the moment? Or
yeah, absolutely, yeah. So drop us an email or give us a tweet. So do follow us on Twitter, drop us a tweet, send us a message, and we can either speak by email, or if it's easier, I can arrange a quick call with someone to discuss things in more detail.
Perfect. I think the last thing was just, you mentioned about the webinars. Where are these going to be advertised? Will they be through SCTS or?
So there'll be a combination. So again, if you follow our Twitter page, we regularly tweet, and also we send out regular emails through the SCTS. But we also have in the SCTS bulletin, we normally have a little a section every article. But yeah, probably email and tweet is probably the best way to find out about this.
Brilliant. Thank you ever so much, Ricky, for joining us today. Brilliant. So we'll head to our final speaker for this session. So that's Sean Griffith, who is going to talk about setting up the SCTS Nursing and AHP Research Directory. Sean is currently employed as an advanced clinical practitioner in cardiothoracic surgery at King's College Hospital, London. He graduated from the Lothian College of Nursing in Edinburgh, had a BSc in critical care nursing from King's College, London, and an MSc in advancing clinical practice from London South Bank Uni. He has over 2 decades of postgraduate experience in cardiothoracic surgery, including initiating quality improvements in patients, cardiothoracic intensive care, high dependency, and the ward and outpatient settings. So Sean, the floor is yours.
Hi there, can you see that okay?
I can't. Can anyone else? It could just be mine.
Let's see.
No, not yet.
Okay. No.
I can see you, Sean, but not your presentation.
Yeah, okay. Just hold on. Sorry about this. Rosalie, is there any chance that you can bring my presentation up there?
Yeah, I'm just going to try to share my screen now. Just one.
Brilliant. Thank you, Rosalie.
Thanks a lot. Yeah, so I'm going to give you a little update on our directory that myself and Laurel Jacob did, that's just gone live over the last couple of days, thanks to Zoe. Zoe's hard work. if you wouldn't mind flipping to the next slide, please. And the next slide again, please. So yeah, I'm going to talk about setting up the directory, the members that are linked to the directory, also the website with the links and the information that that contains to help people that are interested in getting into research at any level. And then go on to kind of current research themes, both at a local, national and international level, that are kind of leading into why it's such an exciting time to get involved in any kind of research as an allied health professional or a nurse. And then just a little shout out for a webinar that we're going to be doing next year. It's going to be the second one. There's going to be one later this year in the autumn that Professor Julie Saunders talked about, linked to clinical and academic careers connected to research. And the next one will be more, next year will be evidence research in practice. If you would mind going on to the next page, please, Rosalie. So again, Professor Saunders has kind of talked about a lot of this earlier, just the basis of the group. It was formed in 2017, pan UK and Ireland membership, though at the moment it's just English members we've got. We did lose an Irish member earlier this year. It's promoting research at any level, cross-pollination of ideas, so within between institutions, within institutions, at all levels of people's careers as well, just encourage research. And the directory's got links to research support and funding opportunities for that as well. Next slide, please. So this is the new website that looks great, that Zoe's set up. It's got the vision, and then as you scroll down, it's got links into the directory. Next page, please. There's aspects of the website that you can access if you are a member, and access other bits that you can access as a non-member. But obviously, if you are a member, you can access things like the bulletin and podcasts and that kind of thing. I guess most of the people viewing this will be members, but I know there are non-members viewing as well. It is an excellent thing to join. The SCTS has so many benefits, and as an allied health professional, it's only £30 a year, which is very reasonable, I think, for what you get out of it. But to get the full benefits of the research directory, you need to be a member. Next page, please. So it's a resource for all members of the non-allied health professionals. And it's, as I say, to promote undertaking, publishing and utilisation of research. It includes contacts for people, including previous members of NAHP that we approached, myself and Laurel, and the current members of the forum as well. Next page, please. So there's a mixture of academic and practice-based backgrounds. Physiotherapy are represented at the moment, but we're obviously open to all other non-allied health professionals if they're interested, pharmacists, dietitians, SCPs. So some of the members on the group have got a research-based background, or are involved in doctorates or have completed doctorates, or are lecturers, academic lecturers. So some of the members have got experience of publishing research, so can help if anyone needs any assistance in that. And also other members have got experience of applying research in practice as well. So once you've done your research and shown it to be beneficial, to how to get that to be used in a useful way for your patients. Next page, please. It also includes directory links for research support. So within the SCTS, we're very lucky to have the UNESCO fellowships. I think the for this year, the application deadline's passed, but very generous, 6 awards of £5,000 each that can be used. That doesn't have to be research, but it would be ideal for research. NHS, obviously, Ricky's just explained about CERN as well. There's opportunities through that. Individual trusts will have, you'll be able to apply for funding there. British Heart Foundation is very active in research as well, and is very generous with its funding as well, so that's another funding opportunity. And if you look on the website, there's other charitable links where funding can be accessed, also Health Education England, and this is an expanding research resource. As we hear about more, I mean, you can always let us know and we can add it to the list. If you hear of other avenues to get funding or support, then let us know and we can add it to the resource. This is a growing resource, so it's only just been set up. So it's something that will be evolving and morphing as we get more information. Next page, please. So just talk about why it's such a good time to get involved in research at the moment. Next page, please. You're probably all aware that just last month, the reporting for surgical outcomes has changed. So it's moved from individual surgeons to reporting from an institution basis on specific procedures. So this is going to be a great opportunity for units to have a standardized practice which can incorporate research from including non-allied health professional research. So now's, I think we're going to be moving from a more fragmented way of doing things at the moment, where individual surgeons might have their own way of doing things, to a more group kind of outcome and planning aspects of things, and you know, that's obviously provides opportunities for us. I mean, this move is very popular with our medical colleagues as well. I think in the recent AGM there was 120 people at the meeting, 70 voted, and it was 100% wanted to move from individual surgeon reporting to institution reporting. So there's a lot of support for this change. There's also going to be less emphasis on the morbidity, on the mortality figures, and more emphasis on the morbidity figures, which will again be good for the group in terms of applying research and improving patient outcomes, using those factors as some of the targets. Yeah, next slide, please. So moving from a local level to a national level, the Getting It Right First Time initiative. Next slide, please. It's across all specialities. I think orthopedics was first in 2013 or 14, and the first cardiac Getting It Right First Time initiative was published in 2018 by David Richens. The update's due to be published later this year. So I have heard rumours it might be delayed because of COVID. But again, this is very high in the priority list, is standardization of best practice. And that includes input from surgeons, anaesthetists, cardiologists, and us as a group, and non-allied health professionals. So again, this is kind of headlining the need for us to get involved in research and then implementing that research into practice. Next page, please. And from an international level, this was touched upon again by Professor Saunders earlier. The ERAS, next page, please, initiative, which, similar to the Getting It Right First Time initiative, is about standardizing care. This is from an international perspective rather than just a national one. But again, this is something as non-allied health professionals we can feed into. Next page, please. This is just a list of the priorities that have been highlighted at the moment. Again, there's a lot of crossover between that and the the cardiac priorities that have been outlined by Professor Saunders and Ricky. So again, that all feeds into research that we can do. Next page, please. So just a shout for the webinar. This is going to be the second webinar. It's going to be a clinical and academic webinar in the autumn, and then next year we plan to do a non-allied health professional research into practice webinar. It's just 2 out of 3 quality improvement projects fail, so it's to kind of give an idea of strategies to help improve the success of any research that you've got, which is going to improve patient outcomes and how it's more likely to work and be successfully implemented. Next page, please. And that's it. So has anyone got any questions at all?
Brilliant, thank you ever so much, Sean. There is just a few questions, and then we'll open the floor up for the other speakers as well, if that's okay. So I think the main thing that people are sort of asking is sort of what's the commitment in terms of to join the directory. Is there a certain amount of commitment needed for individuals?
To join the directory, if you've got background in research, it can be at any level at all. It doesn't necessarily have, I personally have done very little research, but I have done a lot of quality improvement initiations, and I'm well aware of the barriers that can be for that. So it depends what you want from the want to give. You can give it from a level of implementation, or if you've published research, or if you've undertaken research, and if you want to share that experience with others, then I think it's a 250 word resume of what you've done, maybe a list of publications. We do have a form that you can fill in that if you email me, or if you email another member of the group, we can send it to you just to fill out. But it's basically about your background, any research that you've done, publications that you've done, obviously what your current job is and what that feeds into the role as well. But I mean, we're open to anyone with experience really to act as a mentor for others. So it would be for junior colleagues or colleagues that are maybe wanting to look into an area that you might have expertise in. But yeah, we're definitely looking for more members to join that group.
Super, thanks, Sean. And I think, as Julie mentioned in the first session, the SCTS admin email is often an easier way if people either lose emails, etc. If you put it through the SCTS admin, the admin team can then pass it on to Julie and then the relevant parties as well.
That's right. I think my email address is on the next slide, so you feel more than welcome to email me as well.
And we
yeah.
are hoping that the sessions from today will be available to the members after the session as well. So if people want to sort of relook over them. And in terms of sort of the commitment, Sean, what would you expect individuals to have to do once they are part of the directory?
Well, it's we're not. I mean, the commitment. To be honest, it's difficult to say because we've just set it up. Today we've got a mentoring session, kind of this afternoon. At the moment, for the group, we're having monthly meetings, but it would depend. It could just be a touching base for someone that's unsure of a way to go about something, so they just want a bit of initial advice, or other people might want a bit more support through the process as it evolves. So I think the commitment, it doesn't have to be a huge commitment, but I think the more that you maybe put into the role, the more you might get out of it. But it would be depending on the people that you're mentoring, I think. Because we haven't really had experience of it as well. It's difficult for me to say for certain what that commitment's going to be.
Yeah, no, brilliant, Sean. I think it's just about supporting people and bringing different people's backgrounds into the directory will then help hopefully try and improve sort of engagement and for sort of nursing and HPs to get into research.
I think as a group, we're not as embedded in research as our medical colleagues, and a lot of people find it quite daunting as well, so especially maybe newly qualified staff. So it's maybe to break those barriers down as well and just make them see that it's not as daunting as it might first appear. Yeah, no.
We've got about 5 minutes left until the end of the session. So we were going to open the floor up to sort of all of the speakers, but also all the people listening as well. I think we might just go back to the first question. I know Julie answered it earlier, but maybe Ricky or Sean could have their input in terms of what do you think the challenges are getting nursing and HPs into research, and how can we overcome them? If you want to start, Ricky.
Thanks. I think Julie touched on it earlier. So I guess it depends on which hospital you're at. So it's about getting maybe the more senior members who are more research active to try and, I think it's down to everyone to try and get them to provide the opportunities for, for nursing and allied professionals, because, traditionally, for example, consultant surgeons might, just stick and train, surgical colleagues, but actually if you can mentor an NAHP, you can deliver the same piece of work. And actually the doctors tend to rotate around every 6 months, so if you invest time in someone who's going to be there normally for a number of years, you probably get more out of it actually than you might think. So it's just about raising awareness, I think, as well.
Yeah, no, I agree, Ricky. Sean or Rosalie, do you want to add anything?
Rosalie? No, I think that's right. I mean, I think the commitment can be varied. It depends really on what the person that you're mentoring, what they want out of it as well, and how much guidance they need. But it doesn't have to be a heavy commitment. I wouldn't say, it can maybe a couple of hours a month might even do it. It depends on the person, obviously, but.
Yeah, no, super. And maybe just to wrap up this session, especially working within the research subcommittee, we would like to know everyone's thoughts. So I know it's been a little bit quieter on the chat, but if people have any ideas, have opinions on what they would like to get out of the research committee, we would be really grateful for all of your opinions, advice, etc. Because as Julie and Sean have said throughout this morning's session, it is new. Originally, it was just Julie on her own, just leading the research group, and actually with the subcommittee, it has managed to broaden what we can provide for the SCTS members. So actually, we're keen to keep on growing the research subcommittee, like with the directory and the different webinars, etc. So if people have more ideas that they would like to put forward, then we would be greatly appreciated for any of that. So either email in one of the subcommittees, or like I said, the SCTS admin email as well, because then that will just get filtered down to one of us as well. Does anyone else want to add anything before we close the session?
I just wanted to, it's just a practical bit of advice to finish on, which might be helpful, is leading on from Ricky's point, was that if you're interested in identifying who are your PIs or those that are engaged in research in your hospital and you don't know, so you don't necessarily know where to start, you can get in touch and we can perhaps identify who the research people are in your hospital, or maybe other CERN members there too. So if you really are stuck as to really where to start, then that's something we might be able to help with.
Super, thank you, Julie. Just one, I've just seen a quick question on the chat. So someone just said about presenting their research results tomorrow, but they would like to carry out a national study. How would they go about doing that? I don't know if Julie, if you'd like to start.
I guess it completely and utterly depends on the piece of work and what type of study it was, for example. Certainly, if you want to expand it nationally, if you don't have any research experience yourself, you would need to partner up with somebody that has experience of designing multi-centre studies, knows about the governance of them, how you would get it funded, etc. But it does depend a lot on the type of study that it is. So again, that might be something that signing up for a speed mentoring session in the future, or contacting us directly to look at how we might be able to advise you, might be a good thing to do.
Super, thanks, Julie. I think that concludes the end of our first session. Because it's just gone 10:30. We're going to be starting back at about 11, so if people